Dr. Soma, over to you, ma'am.
Yeah. Am I audible?
Ma'am, you are not
Just,
audible.
just give me a sec. Just a minute. Just a minute. Share.
No, ma'am, we can't hear you. You're not audible at all.
Okay,
We
wait.
can see you, but we
Can you
can't hear you.
Okay.
Mic mode standard. Now,
Am I audible now?
no, ma'am,
Yes,
not
ma'am.
yet audible.
Varun sir, Dr. Ma'am is audible. I can hear her. Maybe some network issue in your end.
Slides are visible.
Yeah. Okay. What about my PPT slides are visible?
No, not it, ma'am.
Not yet. Okay. Just give me a minute.
Hello, Dr. Soma. Am I audible?
Yeah, you are.
Yeah, we can hear you properly now, ma'am.
Sure. I'm just sharing my slides.
Okay. I'll just go ahead with the introduction. Ma'am Soumya just informed me that I was not audible. So today's masterclass is going to be conducted by Dr. Soma Singh. Dr. Soma Singh, Associate Director at Gynecology and Obstetrics at Max Super Speciality Hospital, Noida. Max Healthcare is one of the leading brands of India, healthcare brands, and has multi-specialty hospitals across the length and breadth of India. Now, even in New Delhi, they have three major super specialty hospitals, namely Max Saket, BLK Max, and Max Noida. And in today's modern times, infertility is a big issue. It present in even young couples and older couples who want to, build a family. And it's not the problem limited to just India and Africa. It's a global issue. And hence, Dr. Soma chose today's topic about how to manage, about advancements in managing infertility in infertile couples. Dr.
Thank
Soma,
you. Okay. Thank you for the kind introduction. I wonder if my slides are visible. Anyways, meanwhile, we can utilize the time. I just wanted to know what kind of audience do I have. A very good evening from here. And just wanted to know what kind of audience we have, if I may know, this is specialties.
Okay, we can start. I mean, it will be a good idea if some of the members can introduce themselves. Dr. Ivan,
Yeah.
if we can start with you. Hi, Dr. Ivan. It will be great if you just a little bit introduce yourself. Dr. Oasis. We have Dr. Samuel. He's a general surgeon. He's from Nigeria.
Okay.
I've interacted with him, but we have many new names and faces. Anybody,
Sure.
please, it will be great if you can introduce yourself.
Okay.
Yes, Dr. Manu, please go ahead.
Yeah.
My
Okay.
name
Slides
is
are visible, right?
my name is Dr. Unu Peter from Nigeria, currently practicing internal medicine.
Medicine. Okay. Very good evening, doctor.
Thank you, ma'am. So happy to have you today.
Okay. I am sorry for this getting delayed. Just a minute more, I think I'll take. Trying to share my slide. Is it visible?
Yes, it is visible.
Okay. Thank you.
Check.
Yeah. Okay. Checking. Right. So I think I have already been introduced by Mr. Toma. So we'll straight away go to the topic. Today I'm going to speak on the recent advances in the management of an infertile couple. So as we all know, what is infertility? It is basically failure to achieve a successful pregnancy after a couple has tried for 12 months without the use of any protective device. That is after a regular unprotected intercourse. It may be primary, it may be secondary. Primary means when the couple never had any pregnancy. Secondary means when a couple had any pregnancy, whether it ended up in an abortion or it led to a live birth. It's called secondary infertility. Now, infertility is just not a problem of female. It is a problem, it's a combined problem. Male factor are equally responsible for infertility. It has been seen that in 1/3 of the cases, 30 to 35% of couple are affected solely due to male factors. And in fact, male factors contribute overall to almost half of the infertility cases. And the prevalence is around 15%. That means out of 10 couple, 1 or 2 might have an issue in conceiving. So if you talk about the causes of infertility, as I explained, around 35% is exclusively because of male problem, and another 35% is because of pelvic pathology in the females. 15% is because of ovulatory dysfunction, especially PCOD or maybe low ovarian reserve. 5% are unusual problems like cervical atresia, absent uterus or MRKH, rare congenital anomalies. And if we rule out all the causes of infertility, there are still 10% of the cases which remains unexplained. So 10% is the unexplained reasons for infertility. So when should one start evaluating their infertility? So as is okay. Okay, so as I explained in the definition, after 1 year of intercourse, but in some special conditions, a couple requires investigation even before completion of 1 year. And these conditions are if a woman's age is more than 35 years, woman who has irregular menses, woman whose history is suggestive of any pelvic infections or endometriosis, a woman who had a previous ovarian surgery, a male who had a known or suspected poor semen quality, if any man or woman had a history of chemotherapy or radiation therapy, because it leads to death of germ cells, and we know they're going to be sterile or low infertility. So in for the presentation, I'll be talking about the management steps, both the standard practice, what do we practice, and what are the updates on those fields. So management starts with the initial assessment, like history, physical examination. I'll be touching on the lifestyle modification, the ovulation-inducing agents, the fertility-enhancing surgeries, IUI, ART like IVF, ICSI, and fertility preservation and rejuvenation therapies. These are the latest in the field of assisted reproductive techniques. So as I said, management started with a proper history. History is the key for any clinical condition, as the same in the medicine, same in the surgery, and then follows the physical examination and the labs of specialized test. So for female partner, we have to start a medical history. It starts with the age. In fact, age is the single most common and single most factor that decides the success of any assisted reproductive technology or infertility treatment. It's the most important prognostic factor, I would say. Duration of infertility is equally important. Sorry, because as the number of years of marriage increases, there is a decline in fertility by around about 20-25% chances. The chances of conception reduces every year. So we have to take the history in detail. We have to ask about any coital difficulties, how regular are her menses, and you have to take the obstetric history in details. You have to ask the previous medical history, previous surgery history, and also lifestyle factors, which are very important, like smoking, alcohol, any recreational drugs, and all. As I told you, age is very important in female partner because as her age advances, there is a decline in the fertility. Optimal fertility in a female is seen between the age of 20 to 30. As the age advances, as you see the age advancing, the fertility goes down, especially after age of 38 and 40. So same with the men, you have to take a proper history. For men, I would say age is important, but you don't see many very obvious changes in the men's fertility with the age, not before age of 50 or so. And with age, what happens, there is a reduction in the semen volume, sperm motility, and also the morphologically normal sperms, but the concentration remains the same. So again, you have to take the history in detail from the male partner. You have to ask for the coital problems or any previous medical illnesses, previous surgical history, any past history of sexually transmitted infections, any drug history and lifestyle factors you have to ask in details. When coming to the physical examination, you have to basically look for any signs of deficiency of hypogonadism symptoms. You have to see if it is an endocrine problem for
Uh,
female.
Dr.
There's any
Soma, sorry to interrupt. Can you put the presentation on slideshow mode, like big screen mode? I mean,
okay.
just requesting for that.
Sure. Just a minute. Just my system is not there. Okay.
No, ma'am, there is that play, no? There's a button play. If you click on that, it'll become big screen. Like on the
Yeah,
top menu, there's that play icon.
I'm trying to do that. Oh, is it okay?
No, it's still
It's
not.
okay. I have done that. It's a big screen now.
Not yet. Okay, let's continue, ma'am.
Let me see. Now you have the big view. You see the slides on the side. This is not my laptop actually, so I'm kind of a problem here. Is it okay? I think I'm not able to do it. I don't understand the things.
No, ma'am. Okay, then let's continue, ma'am, if you're struggling with that. It was a
Slideshow,
doctor,
right? Slideshow kind.
Dr. Ishitu, like doctor is facing some problems, so a big.
Wait. Let me see if I can be held. Slideshow, I will know. Slideshow. There's a play button here, but they're not able to see.
They're not able to see the slides.
And no play button. It is not. Is that okay now?
No, ma'am, we can see the slides, but they are not
You
on
want the bigger
slideshow.
version, something like slideshow, right?
Because some doctors, they have joined from the mobile screen, and going through them is difficult. So if you can maximize the size of the slides, like put it on slideshow mode, that will help.
Slideshow mode only. Fit the slide. No, then I won't be able to see. It's too zoom too much. I think I've done now.
Maybe, ma'am, there must be some lag. It might reflect. So we should continue, ma'am.
Okay. So now coming as I was talking about the physical examination. So you take the weight, take the BMI, because BMI is very important. Underweight, overweight, both can lead to infertility and adverse pregnancy outcome. Secondary sexual characteristics one have to be seen both in men and female. You have to examine for the secondary sexual characteristics whether they are well developed or not. You look for thyroid enlargement, any discharge from the breast in case of female, and you look for signs of hirsutism, acne that shows hypoandrogenemia, and you do a thorough abdominal pelvic examination. Look at the local examination for any vaginal or cervical structure anomalies. Similarly, in male, BMI, you look at the body habitus, you look at the secondary sexual characteristics, you look for any gynecomastia, and male gynecomastia is important, and the genital examination, including the penis, the scrotum, the presence of testis in its location, the size, and also if one is comfortable, can palpate the vas epidermis and look for the cord present or not. Now, if suppose the couple approaches a gynecologist or somebody who is not very well versed in the examination, the male genital organs, so one can start with a simple semen analysis for the male partner, and abnormal reproductive history or a abnormal semen analysis now is an indication for formal evaluation by a urologist or a reproductive medicine specialist. So coming to the laboratory test, it can be divided into two categories. One is screening test. That is screening test for any couple who is planning to conceive. These are the screening tests which should be done. Blood group for both the partners. We have to screen them for any sexually transmitted infections. For female who is going to carry the pregnancy, it's very important that we screen her for rubella immunity, for varicella immunity, and give her the appropriate vaccines. Also, we do a pap smear or LBC to rule out the cervical cancer. You do the HB electrophoresis, hemoglobin electrophoresis to know any abnormal kind of hemoglobin, and hormonal assays as indicated. Thyroid is very important, and I'll also like to do vitamin D levels because vitamin D deficiency can lead to abortions. So you should look for vitamin D levels. Thyroid profile is important, and definitely a strict sugar control is very important before the conception for female. Now coming to the diagnostic test. The diagnostic test that leads us to the diagnosis. That is they help us in finding the reason for infertility. So as I told you, for male, the first and the very simple test is you ask for a semen analysis. In female, you have to check for ovulation. You have to check the fallopian tube are patent or not. You have to evaluate the uterine cavity and find out any anomaly in the uterus like fibroid. Fibroids are very common, and you have to do additional testing based on the history and physical examination.
Uh, Dr.
So,
Soma, sorry to disturb you again. I think there is an issue with slides. They're not changing. On the screen, it
they're
still shows
not.
the slide semen quality and IUI, but I understand that you have moved to diagnostics. So,
No. What happened?
uh, like on screen, the slide that shows is semen quality and IUI, but while you have discussed more topics after that. So slides are not changing.
Slides are not changing. So which slide is it showing?
Semen quality and IUI.
How come that? Which one are you sharing? What about the previous slides? Were okay? Till where did they see?
Yeah.
Which one? Which slide are you able to see now?
Same semen quality and IUI.
I shared something else.
Ma'am, maybe you can stop sharing screen and then reshare it.
Wait, just a minute. Give me.
Dr. Soma, if you share the file with me, I can do the screen sharing if you're okay with that.
So was that the slide visible since since the beginning, or it just happened now?
No, in the beginning, ma'am, slides were progressing, but we got stuck at that slide. Ma'am, if you want, you can share the file with me. I'll do the screen sharing. Okay, we can see the screen now.
Okay, wait, it's done. No, not this one. This is not the presentation. This is not the presentation.
No, this is the presentation. You're seeing the screen now?
Yes, sir. We are seeing the screen.
The presentation. Same, ask about this.
So till where they could see, we have discussed about the physical examination and
Yes, yes.
analysis.
Yeah, I see.
This slide was shared.
Yeah, we can see the slide physical examination male.
Okay. And the problem is still there that you still don't see the full screen, is it? Now, is it okay?
Now we can see the full screen.
Okay, great. Thanks. Sorry for the disturbance. So we were talking about the tests, two kind of tests, screening tests and the diagnostics tests. So as explained, blood group and sexually transmitted infection has to be screened in both the partners. And for exclusively for female, we'll be checking for rubella immunity, varicella immunity, HB electrophoresis to know any abnormal kind of hemoglobin, a pap smear or LBC to rule out cervical cancer, and hormonal assay, which are must are HbA1c to know the sugar control, the thyroid profile, and also the vitamin D level. Now, coming to the second set of tests, we call diagnostic tests that help us to find out the reason for the infertility. That includes, for male partners, it's a simple semen analysis test. For female, we have to do the test finding out any ovulation disorder and to check whether the tubes are patent or not. We have to check the uterine cavity, uterine anomaly, and additional testing based on history and the physical examination. So coming to the latest WHO reference values for semen. Now, one thing I would like to mention here for everyone whosoever is advising semen analysis, that instruction should be very clear to the male partner that semen has to be given for testing after 2 to 6 days of abstinence. It should always be examined within 1 hour of ejaculation, ideally 50 minutes, but definitely within 1 hour of once it has been given. So the standard practice is that the semen should be collected in the vicinity of the lab where it's going to be evaluated. And according to WHO, the ideal method of examining a semen is by manual examination under microscope and not the automated or computer analysis of the semen. So the lower limit for normal semen analysis are that semen volume should be 1.4 ml and above. The lower limit of concentration is 16 million per ml. Total motility is 42%, progressive motile should be 30%, and viability, that is the live sperms, at least there should be 54%. The morphology, that is the normal sperms, using the strict Trigerber criteria is 4%. If 4% and above sperms are normal, that is considered a normal semen analysis. The number of round cells or the leukocytes should be less than 1 million per ml.
Dr. Singh, we have a question. We have a question. Do you want to take it now or at the end?
I think the end if we take, otherwise we I don't know. Just please keep writing or sharing the questions. We'll answer at the end of the session. Would be better.
Okay, okay. So please keep writing your questions as you have them, and at the end we will take them one by one.
They keep posting the questions. So I will not be going to detail of each and every test. Just we know if somebody who has the female has a regular menstrual history, she's a regular periods every month. It's associated with the pre-menstrual molemia that she's ovulating regularly. We can check a mid-luteal or the mid-cycle progesterone. If it's more than 3 nanogram per ml, that progesterone is being released and it's the ovulatory cycle. There are kit available, commercial kit, to know the time of LH surge and the ovulation. And the couple who live overseas, who meet hardly for a few days in a month or a year, they go for checking the ovulation using these kits. Transvaginal sonography definitely tells you when the ovulation took place, and that's the ideal method, but definitely it's a cumbersome. It involves visit to the clinic and all, and no one is nowadays does the basal body temperature to know the ovulation. Coming to the assessment of fallopian tube, the first and the screening test which is commonly used is hysterosalpingography or HSG, because it tells you about the uterine cavity. It tells you how the tubes are, how the lumen is, whether it's a proximal block, whether it's a distal block. And also sometimes it has a therapeutic effect. The flimsy adhesions of small blocks get cleared when you're doing a HSG. There's also another modality we call sonohysterosalpingography, where you push the saline using a TVS, and you push the saline, do the TVS, you push the saline, and then you again do the TVS to check. If you see fluid in the pouch of Douglas, there's at least one tube is open. But then it's difficult to comment which one is open, which one is blocked, whether both were open or one is blocked. There's salpingo contrast sonography, that here you will be able to see the contrast. So it is easy to make out which tube is patent and which is blocked. Laparoscopy definitely is the standard method because it just not tells you about the status of the whole pelvis. You're able to see the whole pelvis, the tubes, and also you can correct in tubal blocks in the same sitting. Coming to the uterine cavity assessment, HSG, as I told you, it's the best initial test. When you're doing HSG, it tells you the cavity as well as the tubes. TVS ultrasound is must. Any gynecologist, any clinic which has an ultrasound should be done in the very first visit of female if she's visiting your clinic, because it gives you a lot of information. It gives you information about uterus, the size of uterus, about the tumors in the uterus, whether there's any cyst in the ovaries, and a lot of things about the pelvis it gives you. And another methods that we can use to check the uterine cavity is the saline infusion sonohysterography. This is the picture of the sonohysterography. You can see the saline is pushed using a IUI cannula or a Foley's catheter, and you can see that cavity is regular. It is very useful in the cases where you're suspecting a small polyp or intrauterine adhesions. Hysteroscopy is the definitive method, but definitely it's a surgical procedure, needs to be done under anesthesia unless it's a office hysteroscopy. Now, lots of people as well ovarian reserve. Ovarian reserve you can give, but it is not a screening test. It is not indicated in all the females who are visiting for infertility. It is best reserved for women who are at increased risk for having a reduced or the diminished ovarian reserve. And so these cases are if a female is more than 35 years, a person suffering from unexplained infertility, if there has been a family history of early menopause, history of previous ovarian surgery, a female smokes, and she has demonstrated poor response to gonadotropins in the past, and if she's suffering from endometriosis, one can go for ovarian reserve. And definitely before doing a surgery for endometriosis, one should look for ovarian reserve. Now, if you come to the secondary level diagnostic test, we told you that semen analysis is the first and foremost test to know whether male is fertile and not. But you need further investigations to find out the reason why the semen is abnormal. Why is it abnormal? That includes the endocrine evaluation, urology evaluation, genetic evaluation, and sperm function tests like DNA fragmentation index. So what are the indications for doing an endocrine evaluation in a male partner is whenever you see a semen where there is no sperm, azoospermia we call it, or the sperm count is very less than 10 million per ml. So you advise a FSH and total testosterone. Remember that testosterone, the level is highest in the morning hours. So you always say that the sample should be given morning hours, 7:30 to 8:30 a.m. and along with the FSH. So FSH and total testosterone will tell you where the problem is. And also testosterone is recommended in FSH in cases there's impaired libido, there's erectile dysfunction, or the atrophic testes are there. If one finds that the total testosterone is less, if it is less than 300 nanogram per ml, one can go for extensive test that includes FSH, LH, free testosterone, and also prolactin. If you're suspecting, especially the background of history, if this was a history of headache or some gynecomastia, one should go for prolactin as well. If the person is obese, especially central obesity, one can go for estradiol as well, because change in the ratio of testosterone estradiol can also lead to abnormal sperm, the abnormal semen. Neurological evaluation, usually if suppose the male partner is seen by a urologist or a general surgeon who can do the proper evaluation, it tells you lots about, you don't need exactly a scrotal ultrasound, but if a gynecologist, she's not very confident of doing a proper examination, one can advise for scrotal ultrasound. That tells you about the scrotum, if there's any mass in the scrotum, abnormal mass, whether testes are present, what is the volume of testes, any underlying varicocele, it gives you a lot of information about that. And TRUS, that is called transrectal ultrasound, is indicated whenever you are suspecting a problem, obstruction in the lower genital tract in the male. And that is suspected whenever there is a low volume ejaculate and where the vas is palpable and the normal testicular size, and still you are getting a zero sperm or very lower sperm count, one should rule out lower obstruction in the lower genital tract in the male, and so you can go for a TRUS. Renal scan is only in selected cases. Vasogram is only when you are trying to remove a block. Suppose you are planning to do a vasovasostomy or epididymal and vasostomy, the role of vasogram is there. Genetic evaluation is indicated only in cases of azoospermia, that is absence of sperm, and also severe oligospermia, which is non-obstructive in cause. And how do you know whether it's obstructive? And you suspect it's obstruction and non-obstruction just by doing the physical examination and the blood test. Suppose a person who has a normal testis and there's a palpable vast difference on physical examination, you will know there is a obstruction, and that's the reason there is no sperm in the semen or the very low count. So these are the cases you suspect that in spite of having a normal size testis and a palpable vast difference and epididymis, there is no sperm, you suspect obstructive azoospermia. And with the low, similarly with the severe oligo, very low count, when you are suspecting obstructive cause, you have to go for genetic evaluation. The most common evaluation we advise is karyotyping. In cases of non-obstructive azoospermia, one should also get the Y chromosome microdeletion tested. There is a region called SRY segment that will tell us if it's deleted, that will tell us that the patient is definitely azoospermic. And in special cases where you see there is absence of vast difference, especially bilateral absence of vast difference, you have to look out, you have to check for the cystic fibrosis gene. So one have to check for the CFTR gene mutation in cases of congenital absence of vast difference. Now, there are many cases, we call it unexplained male infertility. A semen analysis gives us just some information, but there are many male who are still, infertile in spite of having a normal semen analysis. So what are these sperm fraction tests? They actually provide more clinically useful information and diagnostic information regarding the sperm function. So these are sperm DNA integrity or the seminal reactive oxygen species test, the acrosomal reaction. Last three, the acrosomal reaction, the hyperactivity and motility, and all this for research purpose. The first two I'll be concentrating because these tests we are doing commercially. These tests are available and really helping us in treating these couples. So everyone should know what is reactive oxygen species. Reactive oxygen species basically normally also in the body during the metabolism of oxygen, few free oxygen radicals are produced called peroxide or oxide or hydroxy. There free radicals are produced, and there is also a system in the body, we call it the oxidant this is the antioxidant system. So this is the oxidative reactive stress. This is oxygen reactive molecules or the radicals, and there is a system which prevents the body against the damage caused by this free oxygen radicals. We call it antioxidants. So whenever there is imbalance in the ROS and the antioxidant mechanism of the body, it leads to damage of the sperm function. And there are other factors, the environmental factors that can lead to the increase in ROS formation in the body. And these are like, as shown in the slide, male accessory gland infections, environmental factors like drugs, if a person smokes, if pollution, radiation, and varicocele, or if there's a systemic disorders like diabetes, cancer, means any chronic inflammation disorders, including cancer, can cause increased in the formation of this reactive oxygen species and increases the oxidative stress in the body, which actually causes the spermatozoal dysfunction and can lead to infertility. So there are different types of method of measuring ROS. One is direct method and one is indirect method. Directly method usually are done in the research setting. Indirect method is you do the DNA fragmentation index, because they damage the sperms at the DNA level also. So we do a DNA fragmentation index where we see whether the sperm's DNA is intact or not. The sperm DNA, one have to know that the sperm DNA is contained in the sperm head. And it's a big structure. Sperm head is a big nucleus and a little bit of cytoplasm only. And this DNA is concentrated in the sperm head. And there's a DNA and also there is a binding protein. We call it nuclear protein. So there is basically very weak defense system against this attack by the radicals, free radicals. And So DNA integrity assessment is suggested as an, in fact, independent additional marker of male infertility to give most conclusive information on the sperm DNA. In the picture shown here, as I've seen, the normal DNA DFI, we call it, DNA fragmentation index should be less than 15%, and that is suggestive of a good fertility potential. If it's more than 15%, is still between 15 to 25, it is kind of slightly lower. If it's more than 25, definitely poor fertility potential. So which are the cases we are doing the DFI? Definitely, because it's not available at all the centers. It is done for selected cases only, especially as suppose male age is advanced. If a person is obese or is suffering from diabetes, he's a smoker, he has varicocele. As I told you, these are the different reasons for increased ROS and so increased chance of DNA fragmentation. Post chemo radiation therapy, a couple suffering from unexplained infertility. Suppose a female had one partner and she gave birth to kids, and now she cannot get pregnant with the other partner whose semen is otherwise normal. There really you have to check for this DFI. It will help you in find out the cause. And recurrent pregnancy losses also, it is found to be very useful. So this is the case, one of the case I want to share is related to DFI only. So here was a couple who suffered with primary infertility. Female was of 32 years of age. Male was 33-year-old, and they were trying to get pregnant for 4 years. On investigation, female had all the normal findings, and she had a normal ovarian reserve as well. Male used to be a smoker, but he had a perfectly normal semen analysis. They had 3 cycles of IUI. They got this IUI done before coming to me. So outside my department, and with the ovulation-inducing agent were also used, but they didn't have any success after these 3 IUI cycles. So when they came, so a working diagnosis was made of unexplained infertility. So as I told you, we did the sperm DFI, and DFI was because he was a smoker. There's only positive thing I saw. Okay, maybe there's a problem with the sperm function. We did a sperm DFI and it was found to be high, 42%. So we counseled them for ICSI because anyway IVI was not working for them, and he was a smoker and the DFI was high. So easily, so it's kind of also helps a couple to make decisions. We asked them to get ICSI done. That will be helpful, and ICSI was done, and female conceived after first embryo transfer itself. She's 5 months pregnant now. So coming to the treatment of part, we have done the examination, history examination, and the investigation part. The treatment starts with the lifestyle modification. This is very important. A couple who is planning to conceive should have very healthy lifestyle. Sorry.
Just not disturb
Because
anybody
healthy
on
seed,
the road.
is there any question?
With the load on the
No, it was accidental, ma'am. You can continue.
Okay, so because a healthy seed will only can give rise to a good healthy plant, we say. So a diet and exercise are very important. They go a long way in managing the weight. Smoking, alcohol definitely has to be stopped because it can reduce the function of sperm as well as the female. It can reduce the implantation potential and it affects the quality of eggs. So smoking, alcohol cessation for both the partners. They are advised to avoid excessive caffeine, not more than 250 mg per day, and avoid taking drugs. Do yoga and meditation to reduce the stress levels. And second would be medical management. I'll be talking about surgical management. And fourth mode of treatment is the assisted reproductive techniques. So just 2 slides regarding the fertility drugs. If you talk about fertility drugs in female, natural cycle, there's a single dominant follicle that forms either of the ovaries, and it is this follicle growth is governed by the FSH, which is released by pituitary, and there is LH surge that takes place, which leads to ovulation. In stimulated cycles, where we are giving the ovulation inducing agents, or so we're doing a super ovulation, means we're trying to form more than one egg. We've used different kind of fertility drugs, maybe gonadotropin or different kind of drugs. Here, the HCG used in place of LH. So it's called LH. In case of LH, we are giving a human chorionic gonadotropin, and after that, the ovulation takes place. Either the couple try naturally, we call timed intercourse, or one can have IUI, or we can have oocyte pickup for IVF. So one term I wanted you to know, that is called super ovulation. That is, you aim is to form more than one egg. And this term called controlled ovarian stimulation, that is used in IVF, where you're producing more than just 2-3. You are producing as many eggs possible depending on the ovarian reserve, but then it has to be controlled so that patient doesn't land up in ovarian hyperstimulation. So because here you are giving exogenous gonadotropin, so definitely there will be more eggs that will grow simultaneously. So most commonly drugs that we use, I think most of the gynecologists and the fertility specialists would be aware of: clomiphene, the letrozole, follicle stimulating hormone. We have human menopausal gonadotropin, and HCG. I told you this is used for a trigger. It is used in place of LH surge. And special patient groups would need dopamine agonist like cabergoline and bromocriptine. That is in case they have high prolactin levels, and gonadotropin releasing hormone and its analog are used as a trigger also nowadays, and also in downregulation of the cycle in IVF. And they are insulin sensitizing agents in persons suffering from diabetes or in PCOS. Now, what about a male? Medical management, male infertility has a very, there's a very small role of medical management in male infertility. So where to use it, one has to know. One has to know, when I told you, after doing the endocrine evaluation, we will know whether a male partner needs, whether he can be helped with the medicines or not. So look at the total testosterone level. Medicine has a role only if the total testosterone level is low in the male partner. If it's less than 300 nanogram per deciliter, then you look at the FSH and LH levels. Either they are normal or elevated, or if they are low. So low testosterone with a low FSH LH is definitely a case of hypogonadotropic hypogonadism. Now, low testosterone with normal or elevated FSH LH, then you go for the testosterone oblique estradiol ratio. Normally, it is less than, normally it is more than 10, because testosterone is high, estrogen should be low in male. So if it's more than 10, it's a case of pure, failure, hypogonadism. But if the ratio is reversed, that is the ratio is less than 10, that means there's an increased aromatase hyperactivity in the periphery. I'll tell you what is aromatase enzymes activity. So male hypogonadism, told you, low testosterone, low FSH, LH. So, and they will have very low, and so basically they are very congenital cause. They can be acquired causes, and they are helped with, they are treated with the gonadotropins, FSH, HCG combined, or FSH, LH combined. And the second group of male who are benefited by medical treatment are who have this aromatase hyperactivity. So these are the males, typically they are obese and they have central obesity, truncal obesity, because what happens normally, this testosterone gets converted to estrogen, androgens get converted to estradiol in the adipose tissue. So a person who has more of adipose tissue will have more of estrogen, most of testosterone converted to estrogen. So as a result, there is a sperm abnormality. In these cases, the medicines which are useful are aromatase enzyme inhibitors. These are anostrozole or letrozole or testosterone that we use. What about the cases of pure hypogonadism? So usually they have normal to elevated gonadotropins with low testosterone and the normal testosterone estradiol ratio. So if a male has a severe oligozoospermia, or if it's a non-obstructive zoospermia, definitely they will are the candidates for ART, like IVF or ICSI. But a few male might be a candidate for, trying, if they're not ready for IVF ICSI, they might be benefited by use of anti-estrogen drugs. So this is just a study proving this, that the estrogen drug like clomiphene has been found to be useful in the meta-analysis reports. Now, what about the oral antioxidants? Probably every physician is writing at least one multivitamin or antioxidant for sure for male infertility. Even if it is not checked, doesn't have anything, you will definitely write one, agent that has multiple vitamins and multioxidants. So as I told you, this is definitely indicated where infertile men have oxidative stress. But definitely we are not measuring the ROS, in the normal clinic or the small centers. We're not measuring the ORS, or we're not doing the DFI. So probably everyone is writing empirically antioxidant. So, but if you take a proper history, you know there are chances of having oxidative stress if a person has a varicocele, an infection, if he smokes, if he's taking medicines, or he has some chronic systemic illness. And also one has to look at the concentration of WBC or leukocytes in the semen. If it is high, that also indicates that there is chances of high reactive oxygen species. So there are many antioxidants that's available in the market in different combination permutations, zinc, N-acetylcysteine, ascorbic acid. I mean, as such, there is no proof which is superior, which is good, which is better than the other, but different combinations are being used. Now coming to the surgical treatment of infertility, we have hysteroscopy, laparoscopic, robotic now. So we also are doing all kind of surgeries for enhancing, we call it fertility enhancing surgeries, hysteroscopic surgery for uterine fibroid, polyps, hysteroscopic tubal recannulation we are doing, hysteroscopic saniculisis for adhesions, hysteroscopic septal resections, and laparoscopic, we talk about laparoscopic, lap removal of endometriosis, myomectomies laparoscopically or robotic, lap tubal recannulation also being done, and lap ovarian drilling in selected cases, and also the role of surgery in male infertility, where a person has a severe degree of varicocele, which is associated with the semen abnormality, provided that the female examination findings are normal. And also in cases of obstetric azoospermia, suppose there's a midline cyst in somewhere lower down genital tract, that can be removed. Now coming to the assisted reproductive techniques. So what are assisted reproductive techniques? Basically any treatment that deals with means of conception other than the vaginal intercourse is termed ART. That includes IUI, that includes in vitro fertilization, and that includes intracytoplasmic sperm injection. So coming to IUI, as the name suggests, we are putting the semen in the uterus. And how do you do it? Basically, what is the purpose? That you place the sperms, the washed sperms, they are washed in special media so that we increase the concentration, remove the anti-sperm factors present in the semen. So we remove the anti-sperm factors that are present in the semen, and then we place it near the time of ovulation in the uterine cavity. So definitely the indication, if IUI will only be helpful if the female has at least one patent tube, and where the semen is not very bad, it's mild male factor infertility, unexplained infertility. In male, I would say where there is a sexual dysfunction, erectile dysfunction, there is very useful. And unexplained infertility also, suppose a female has anti-sperm antibodies or some cervical factors, immunological causes, there also it's fine to be useful. Mild endometriosis cases and immunological factors, where there is a HIV or HBsAg infection, discordant couples, male is suffering from HIV and the female is not there, you can do the IUI by doing the special preparation and you can just inseminate. Whenever one has to use a donor semen, IUI can be a good option. But if you keep on doing IUI doesn't have very high success rate. If you're using ovulation inducing agents, the success rate is around between 10 to 15%. If you're using gonadotropins, it's increases to 20-25%. So if you look at the cumulative pregnancy rate, it does not increases after 3 cycles. The cumulative pregnancy rate is highest as high as 30%. That's all. It doesn't increase after 3 cycles. So if there's no success after 3 cycles, one should shift to IVF. So indications for IVF are tubal disease, as I told you, the bilateral tubal block, or the tubes are not blocked, but anyway they're not functioning because of previous PID or previous surgeries. A female suffering from moderate to severe endometriosis, a male factor infertility, a severe male factor infertility would require ICSI. Whenever one wants to preserve the reproductive capacity in cancer patient, we collect the eggs, we do the semen freezing or we do the embryo freezing. The high responder, suppose you started simulating a female with PCOD for doing an IUI and you gave gonadotropins because she was not responding to drugs and she suddenly hyper responds. In that case also, to prevent cancelling the cycle, one can go for ovum pickup and do IVF. When one has to use donor eggs, IVF is the only option. And also when one wants to have a surrogate mother or the surrogacy is indicated, one has to go for IVF. So if we talk about the basic steps, the first step is ovarian stimulation. The aim of ovarian stimulation, I told you, is to get many co-mature eggs, because normally only the one egg matures in the female's body. The rest, there are many which are getting atrophied every cycle. A female loses eggs every month, irrespective of whether she's bleeding, whether she's not bleeding, whether she's pregnant or not pregnant. So by giving the injections from outside, what we are doing is just rescuing those eggs. It does not lead to depletion in her ovarian reserve or anything like that. So depending on one's ovarian reserve, only one will have the number of eggs that will respond. Second step, oocyte retrieval. Third is fertilization, either conventional IVF, ICSI or PICSI that I'll be discussing. Then there's embryo culture in the lab, and then do the embryo transfer. So definitely procedure differ considerably in order to optimize the treatment, because now we have moved from one size fits all to the tailor-made protocol. The stimulation protocol, the doses, everything is very individualized. These are the standard conventional two types of regimes that we use. We call long protocol and the short protocol, so called antagonist protocol. I'm not going to detail. Now, new protocols, that is we call duo stimulation. That is for person who have a diminished ovarian reserve, or in short, we actually stimulate the cycle twice, back to back, after a gap of 4 to 5 days. Initially, the classic teaching has been that there is a single wave of recruitment of the follicles, that we have follicular phase, one egg grows, and then the die, and there's a luteal phase. But later we came to know there are many waves that are, recruiting the follicles within one cycle, one menstrual cycle. There are many waves of recruitment. So we take advantage of that, and we do the dual stimulation within the one menstrual cycle. We stimulate, we pick up the egg. After 4 days, we again start stimulating and pick up the egg. So this type of stimulation is helpful in cancer patient, where she has very short time to preserve her eggs as a maximum number of eggs she can. When a person has very limited time, suppose somebody is coming for international patients, or somebody who has very low ovarian reserve and they want to have maximum eggs before they get older or before they travel, there this protocol is used. So after stimulation, what we have to do, definitely we have to keep an eye that she doesn't go into ovarian hyperstimulation syndrome. We check by TVS follicular study. We do look at how many eggs are forming, how are they growing. Next step is oocyte pickup, or we call it collection of eggs. That's a very simple procedure, DK procedure. It is done under ultrasound guidance through transvaginal route only. We collect the eggs. So this is the scene from our OT. And this is how the eggs look like under microscope. This is actually the black dots that you see are the eggs, and the surrounding, that opaque, the hazy part you're seeing are we call it supporting cells. We call it oocyte corona cumulus radiating complex. So OCC complex this is, and the black dots are basically the eggs. So now there are two types of fertilization technique. One we call it the conventional IVF, or we used to call it test tube baby, where what we do is we take the culture media in drop forms in a dish, and there we put one egg surrounded by 20 to 30 million motile sperms. So one egg required 20 to 30 million motile sperms, and then we let it fertilize naturally, kind of. It's a natural selection. The best sperm will go and fertilize the egg. Now, where a person is, whenever the couple, where there's a severe male factor infertility, the sperm is very weak or very low concentration, severe oligoisthino, we go for technique called ICSI. Here, you can see there's a holding pipette, there's injecting pipette. This holding pipette is holding basically a mature M2 egg. Now, this is the egg which has been, denuded of all the supporting cells and is now held with help of a holding pipette. And if you see carefully, and there's one needle kind of thing, this is called injecting pipette. There's a sperm inside that. So we take the sperm and we inject it inside the cytoplasm within the mature oocyte. We call it intracytoplasmic sperm injection. Now, there's a new technique also available here. It will be called PICSI. I mean, what it has, this is a special Petri dish, which is hyaluronidase lined. So we call it physiological ICSI dish with hyaluron microdots are there, and that are helpful. These hyaluronidase are helpful in picking up the sperms, which have a very good DNA integrity and which definitely have a good sperm function. So what we do here is after preparing the sperms, we put it in the PICSI dish. So it gets attached to the dots, hyaluronidase dots, and we just use those sperms for doing the ICSI. So again, this PEEX is very helpful in the cases of unexplained infertility and recurrent pregnancy loss. The person who has a high reactive oxygen species levels. So I told you collection semen sample, then you sperm capacitation, you prepare it, centrifuge the semen sample, you take the topmost good sperms, and then you put in this Pixie dish. On the dots, the sperms that gets attached to this hyaluron dot drop, we use only those sperms for doing the intracytoplasmic sperm injections. And this is how the embryo looks like, and then the embryos looks like on the microscope. This is the day one where you see the two pronuclei, and this later in the day one there are two cells you see. Then there are 4 cells on day 2. Then they become 8 cells on day 3. Day 4 they undergo compaction. On day 5 they form a blastocyst. Blastocyst, there's a cavity and there is inner cell mass. There's outer cell mass. Now after that, once we have formed good embryos, comes the next procedure, that's doing an embryo transfer. That's a very simple procedure. Most of the time, 99%, you don't require an anesthesia, just as an OPD procedure, just like an IUI. Patient is made to lie down with a partially filled bladder using a soft embryo transfer catheter. You transfer the embryos under the ultrasound guidance. Here you can see 2 air bubbles. So we place the embryos between when we load the embryos, we put it under between the 2 air bubbles so that we will be able to know where we have placed them, because embryos are microscopic structures. What we can see on the ultrasound are just the air bubbles. Now, if you look at the recent development, IVF lab, what add-ons have come? The one add-ons which has been found to be very useful is embryo glue. Now, ESHRE, also European Society for Human Reproduction and Endocrinology, says that embryo glue has some role in increasing implantation rate. So it is found to be very useful in couples who have recurrent implantation failure, where you're making good embryos and still it's not getting stuck to the embryo to the endometrium lining. Because again, this embryo glue is rich in hyaluron. For implantation to occur, there is adhesion, there's a position, this adhesion, the penetration has to take place. So this embryo glue is found to be one of the factor that can increase the chance of pregnancy. Now, after we have placed the embryos, there's a luteal support. Why the luteal support is needed? Because whenever we're doing IVF, basically we're destroying the corpus luteum. And the corpus luteum function is actually dependent on the pituitary stimulation, and which is suppressed during IVF whether you're using antagonist protocol, you're using agonist protocol. So we definitely have to provide progesterone or the luteal phase support to these females. So coming to the case number 2, it gets very boring, the theory, so I just put the cases in between, how we are using, taking advantage of these newer techniques that we have. So there was a couple with primary infertility. In fact, this was a international patient, came from Cambodia. Female was 34 years old and the male partner was of age 54 years. They came for treatment of primary infertility, and they had a history of previous 2 IVF failures. They had got it done in Bangkok. So on examination of the history and examination, I found that female had PCOS, but so definitely she had a good ovarian reserve, and otherwise the normal pelvis, normal uterus, there's no other problem. Male partner was wheelchair bound, he was diabetic, and he had deranged LFT because he used to drink a lot. On semen analysis, so as expected, he had a severe oligoasthenoteratosis, so severe male factor, and DFI was high. So a severe male infertile factor with a high fragmentation index and female PCOS, and definitely we didn't have any the option. We had ICSI, but because DFI was high and we have this newer technology PICSI available at our center, so we advised them to have PICSI. So we got 16 matured eggs, M2X means mature eggs from female after womb pickup, and we did PICSI for them and blastocyst culture because she had PCOS and the hyperstimulated ovaries were there. So we sent them back. After 2 months, I called them for frozen embryo transfer. And within the first embryo transfer, she conceived. We did 2 blastocyst transfer and she conceived a singleton pregnancy she's carrying right now. It's a 4th month of her pregnancy. So what are the other indications of doing IVF, or what are the other services that we are giving at our center? Is embryo oocyte or sperm freezing. That is indicated in person who has cancer or pre-cancerous condition at young age. And so young age, they're getting cancer, they have to undergo chemotherapy or have to go undergo radiation therapy. So the only option they are left with is to preserve their eggs or sperm. So we are doing that. And any female who has a premature ovarian failure, suppose because of genetic cause, or she's supposed to have an ovarian surgery, or somebody who has a reduced ovarian reserve should go for egg freezing. Then again, somebody who wants to delay the motherhood, especially females, because I told you age is the most important, the prognostic factor that determines the success of any fertility treatment. So a female who is very, suppose she's she because of any reason she couldn't find a proper partner, or she's because she has some her business trip or whatever, she wants to excel in life, she want to first settle um in her work and want to delay the motherhood, there she can have egg freezing. So this is a cryopreservation tanks that we have in our department, where freezing the eggs and embryos and sperm as well. There's one more technique that we have in our department is called pre-implantation genetic testing. So as I explained to you, day 5 embryo is called blastocyst. So sometimes because a couple might be a carrier of some genetic disease, or when the female's age is more than 38 years or 40 years. So we know as the female's age advances, there are chances of increased chromosome anomaly, because chromosome anomaly increases because of the poor egg quality. And so once, if somebody wants to rule out and have only the healthy embryos transferred, one can go for pre-implantation genetic testing. What we do here is, after we have done ICSI, after the blastocyst is formed, we take out the cells from the, I told you this inner cell mass, there is outer cell mass. So take out the blastomeres, that's from outer cell, and subject it to the genetic testing. We call it pre-implantation genetic testing. This way we can select the embryos with a normal chromosome pattern, that is euploid embryos, and then can have transfer. Thank you. I think that was this is the topics really close to my heart. I can go on and on, but it will become very boring for you. And I think it's a mix of audience, so one can free to ask questions. How much, as depending on how much they are interested, and how
No, ma'am,
much
there are a few
detail they would
questions.
like to know.
There are a few questions, and as you answer them, a few more will come. So, first question is
Okay.
from Dr. Chucks. Dr. Chucks is from Nigeria. So, he wants
Okay.
to know what is the importance of HB electrophoresis in evaluating infertility.
HP electrophoresis.
Yeah, importance of HB electrophoresis.
So we use it as a screening tool, before embarking on any infertility treatment, whether I have to give her ovulation inducing agent, IUI, IVF, I want to know she's not a carrier of any abnormal hemoglobin, putting hemoglobin S or hemoglobin C. So I have to know, or whether she's a thalassemia carrier. Hello?
No, sorry, that was a error, ma'am. Accidental.
Okay, so we have to know whether she's a carrier of any of the thing. Suppose she's found to be HBS carrier, or she's a thalassemia minor. So we definitely, that's an indication for evaluating the male partner as well, because we know the genetic risk, the inheritance risk of these diseases. So definitely this needs an evaluation, and if needed, suppose both are carriers, we know that 25% chances of, there'll be chances, suppose thalassemia minor, both are carrier, there's a chances that 25% a baby might be a thalassemia major. So they might need genetic evaluation or PGT. That's the role of PGT here. If somebody suffering from kind of like hemoglobin S or the thalassemia, we can really screen before doing the embryo transfer.
Okay. Now we have a question from Dr. Ivan. Dr. Ivan is from Uganda. So
Mm-hmm.
he had a patient 2 days ago,
Mm-hmm.
and he reported with now almost 2 years of painless uh, micturition, but associated with sperm in urine, mostly at the start, and itching around the pubis, no rashes. No history of conception. He's married, 28 years old. Investigations done were RPR, negative,
Is
acid.
sperm in urine or the blood in semen?
Dr. Ivan, can you clarify? He has written sperm in urine, mostly at the start.
Did he have any kind of pelvic surgeries? I mean, see, sperms are found in urine only. We call it retrograde ejaculation. Usually occurs whenever a male partner has gone some kind of surgeries, the pelvic surgery, the perineal surgeries, or some kind of urological surgery, or sometimes rarely in diabetic. But there usually mostly the problem is with ejaculation. But retrograde ejaculation usually is diabetes or some kind of surgery done in perineum or genital region. That's the indication where we can see the ejaculation instead of going forward goes back and it comes down the urine. So you have to actually, is the person suffering from infertility as well?
Yes, yes, that's what he's saying. He's married, no history of conception so far. And the
Right.
investigations done were RPR, which was negative, RCT negative.
Mhm.
Uh, they were suspecting, as you pointed out, retrograde and
Yeah.
prostatitis.
So
How best can this
retroejaculation.
client be helped?
Yeah,
How can we
epidermis
help?
can be reason for blood, and so retrograde ejaculation, that's where blood is getting mixed in the sperm is getting mixed in the urine. So in case of retrograde ejaculation, what we do is we separate the sperms, and we give alkalinizer to the basically normal conception is not possible. What we can do is either IUI or we can go for IVF or ICSI. So we give the male partner alkalinizer so that whenever the sperm is retrograded in the urine, just after the masturbation thing or whatever, when after the ejaculation, he's asked to pass urine, and we collect it and we centrifuge it and separate the sperms, and those sperms can be used depending on the concentration, either for IUI or for doing IVF or ICSI. So that's the only way out for him. You correct the epididymitis with antibiotics, and after the blood is cleared of infection, we can collect the sperms from his urine and use it for IUI or IVF ICSI.
So, do you suggest that Dr. Ivan share the reports with us, which we
Mm-hmm.
can share with you for your further guidance for this patient?
The same patient?
Yeah,
Yeah, yeah.
you suggest that. Okay, Dr. Ivan, if possible, I hope the answer is clear to you, but if possible, you can share the reports with us. We'll document the case and share it with Dr. Soma for further guidance. Uh, Now, we have another question, ma'am, and the question is, it's in French. It's from Dr. Bafomba from DRC. He
Mm-hmm.
would like to know the principle behind the management of oligospermia, and is there a therapy? There are two questions. First, principle behind the management of oligospermia, and second, is there a therapy for congenital azoospermia?
Yeah. So, oligospermia depends how much low is the what is the concentration. If the concentration is too low, that means definitely if you come to the test, it has to be genetically evaluated. We have to look for SRY microdeletion, and you can get a karyotyping in SRY microdeletion done, and rule out any modifiable factors like in the lifestyle. If he's a smoker, if he's alcohol, something, you advise the lifestyle modification, you give me antioxidant, also get a karyotype done. So after 3 months, you repeat the sample. So the thumb rule is whenever you get an abnormal semen, you have to repeat it after around 8 weeks or 12 weeks, because sperm production takes almost 74 days and another 15-16 days for the transport. So almost 90 days later, you see the effect. So you give the antioxidants, correct the things which can be corrected, modifiable factors, and reevaluate. If there's genetic testing is normal, and if it's improving, well and good, one can go for IUI. We can try medical and try for IUI. If it doesn't improve, one has to go for then ART, assisted reproductive technologies. So this is the approach. You improve the things which can be improved, rule out the genetic causes, and give medical treatment for 3 months at least, and you see the result.
Okay. Because his doctor is a
And
French
in case
speaker,
of
I'll just.
congenital azoospermia, he was asking, so we
Yeah.
have to find out we do the whole hormonal evaluation to find out whether it is a hypergonadotropic azoospermia is there, whether it's a hypogonadotropic hypogonadism, or is it hypo. If it's a hypo, definitely this can be managed medically with gonadotropins. And if it's a hypo, in that case means the testes are already in the failure. There you have to do sperm retrieval techniques like TC, TISA, and then use it for ICSI. In my presentation, I thought of going into details of the different techniques. Also, there are techniques. We are also having this TC. We have this micro TC. We are using microscope also for sperm retrieval from the testes in cases of non-obstructive azoospermia, and then those can be used for doing ICSI and having babies.
No, ma'am, my request to you is after the session, please share the presentation copy with us. We'll share it with all the participants because
Okay, no
uh,
issues.
it will be better for retention and guidance later on, right?
Okay,
Okay.
definitely.
So this question was from a French-speaking doctor, and okay. Dr. Ivan question again from Dr. Ivan. May Dr. Soma clarify something on ovulation and menstruation regarding conception?
ovulation, menstruation, and conception. Okay.
Ovulation, menstruation regarding conception. Yeah.
Okay, so this is the normal physiology. Like in female, what happens? There are two ovaries, there are follicles, the germ cells, forms of follicles. So under the influence of FSH from the pituitary, this follicle grow. But in a natural cycle, only one of the follicle will grow, and rest there are many follicles in a cohort, in a group. There are few group of the follicles will try to grow in one cycle, but the follicle which is more sensitive to FSH, that is, which has more receptor to FSH, will dominate, and the rest few will be undergo atrophy or will die. So the dominant follicle which grows will definitely ovulate. So there is just one egg which is getting ovulated in a cycle, and when it get ovulated, there's definitely a progesterone release from the corpus luteum, and the implantation takes place in the uterus. The fertilization takes place in the fallopian tube, and after 4 days, after 3 days or 5th day, in fact, after 4 days of fertilization, this 4th day embryo comes into the uterine cavity, gets implanted in the uterine cavity, and that's how the pregnancy occurs. But suppose if there's no pregnancy taking place in that cycle, or in that case, the endometrium, actually the uterus also prepare itself for receiving the embryo. So every cycle, when the egg is growing, there is also estrogen released by the ovary, the growing follicle, which prepares the lining of the uterus. We call it endometrium. The lining, the uterus gets ready itself to, they're preparing for the catching the embryo. So if the pregnancy doesn't take place, this lining, this endometrium also sheds, and this shedding in form of menses. So menses is happening because there is no pregnancy. If there's a pregnancy, definitely it will not shed.
Okay, Dr. Soma, so I want to ask a question slightly contrary in nature. All medical guidelines is very clear, and especially in today's, people delay marriage and egg freezing, etc. is recommended. But normally, most people come to you when they are like with the age factor above 35 female age, etc. So people come to
It's
doctor
becoming very common now. I hardly see females before 30.
yeah, so very rarely, like a normal human, like I would go to a doctor when there's problem, although there is all guidelines exist. So okay, what I wanted to ask you is the medical literature, I mean doctor recommendation. So there is this factor age, and hence I mean which is strongly correlated with infertility. But like every individual is different. A female at the age of 45 may have different parameters related to fertility, and a female at age of 30 also. And we also see in modern world there are a lot of pregnancies that happen later in the age. So generally, when patient queries come, this is a very big question. Even before we can bring them to you on consultation. And when they come to India, ma'am, even 40 plus, the extraction of egg is healthy, like 8. So, I mean, we see those kind of things also. If you can shed more light, like how it is
Right. So
individual.
one topic that I didn't cover here, suppose a female of advanced reproductive age, say, as you're saying about 40 or 40 plus. So first of things, definitely they have to be told that chances of see, everyone might have a different ovarian reserve at the same age, as you said. Somebody who has PCOS might have a very good reserve at 40. Number of eggs is not a problem there. Problem is with the quality. As the age advantage is just that not the number which is coming down, the quality is also coming down. Why? Because there's disturbance in the normal mechanism. In the eggs, what happened, there's a mitosis, the meiosis and something. So the meiotic spindle, we call it, dysfunction happens. Just you have to understand the chromosome abnormality chances, the egg chromosome number is not normal. There are more chances that there will be abnormal eggs. So abnormal eggs means abnormal embryos. That means either it will fail to implant, or even if it implants, there are high chances of abortion. So up to 35 years, the chance of abortion is around 12 to 15%. Between 35 to 38, not much change, up to 20%. But after 38, 30 to 41, the chances become high, 25%. After 42 is 50% chances of abortion. So one has to be told that these are the things that even if you conceive with your eggs, you have to be ready that it might land up in an abortion. After 42 years of age, 50% chances of abortion. After age of 45, 95% chance of abortion. So if somebody is very keen to, have her own biological child, want to use her own egg, one technique that might be useful is PGT, I explained to you. pre-implantation genetic testing, because here the chromosome anomaly is a higher risk. So we can screen the embryo before implanting, provided she has enough reserve so that we are able to form a blastocyst. First of all, we have to have a day 5 embryo growing in our lab, and then we do a pre-implantation genetic testing, and then we'll transfer only the embryo which is genetically normal. That is one thing, but it's just not the egg. Second factor that comes to play is also the endometrium. So studies have shown, even if you're using a donor egg, after age of 44 years, chances of receptivity declines even using a donor egg. So definitely is, God has made the system, your reproductive cycle, the biological clock is different from the, chronological aging. So biological clock is clicking away. Want to have a family, you do it at right time. 44, 45 is just not the egg. The endometrium receptivity also goes down. But still, how the science is trying to help them is with something called ovarian rejuvenation therapy that we also have started. We have started using PRP, plasma rich platelet rich plasma. We are injecting the ovaries. I mean, I wouldn't say that is something that will reverse the aging factor, but in some female it is found to be useful. There are papers which are coming up which are claiming that PRP is useful. So we are also trying, and let's see what happens. We need more data on that.
Okay, ma'am. So, what I understood from you is that it becomes a game of probability. Let's say probabilistically,
Yeah.
a healthy egg is extracted. It turns
Healthy
into
extracted, it should be at least
blastocyte, and
those number that we get at is blastocyst. We are able to do a PGT,
yeah, you're
and
and let's say, ma'am, that endometrium also, like there must be many factors as a layman. If that thing is
there's a
also healthy.
chance endometrial receptor also reduces.
So in that case, the abortion chances would be like, as I understood from you, is abortions or that pregnancy failure happened due to
In a
multiple.
natural conception, using the own biological, chances of abortion are high.
No, if let's say if egg is healthy and that PTSI genetic screening is normal
Normal. So
and
that's the only
everything is
chance that
normal,
one can think of. Yeah, she might have a
so
healthy
then,
baby. But you have
so
to
ma'am,
remember, if
then
somebody
don't
has
we?
not conceived in 15, 20 years, somebody, have been trying regularly and not conceived, the chances of conception are less. So might be a problem with endometrial receptivity. But okay, so for somebody who tried later, so after 42 only she got married, or she's trying for pregnancy only after 41, 42, short duration of infertility as such, there you might see surprises, good result, positive results.
Okay, okay, and
So duration of fertility is also important.
okay. So no, ma'am, what I wanted to understand and clarify, because our doctor partners also encounter such questions. So it
Mhm.
is fair. So let's say all those things are fine, and still because age is a factor in terms of carrying the pregnancy, right? That's what I wanted to ask. Let's say everything, pregnancy happened, implantation
Yeah,
happened.
definitely. See, we call it advanced age. Female who is above 35 years, we call it advanced age. And though she is young, in general speaking, but advanced age in terms of biological age, reproductive age, we call it advanced age. So
Mhm.
before giving pregnancy to any females who is above 35 years age, we always screen for her medical fitness. Other than the screening test, we do her liver function test, her kidney function test, a thorough cardiac checkup, and sugar, diabetes, everything that she's fit to carry pregnancy. Those are mandatory things. You do a pap smear, do LBC, rule out cervical cancer, do the LFT, KFT, and sugar, hypertension, everything has been ruled out. Even if she's suffering from diabetes or hypertension, it has to be controlled before she conceives.
Yeah. Now, ma'am, we have a follow-up question from Dr. Ivan. He says, what are the complications of embryo transfer and the risks that come with it?
The embryo transfer complication, as such, procedure doesn't have any complication, but it will depend on what happens after, or how many embryos are you transferring. So first of complication, I would say obviously not every embryo that you're transferring will get implanted. Implantation rate, in fact, is the lowest. If you look at the IVF, why we are not getting the 100% success rate is because the implantation rate is low, around 30-40%. So definitely the chances are that after doing embryo transfer, it might not implant. And if, because you try to increase the implantation rate, you try to increase the pregnancy rate, you transfer more than one embryo. Suppose you transfer 2 blastocysts, or you transfer more 3 or 4 on day 2 or day 3 embryos, chances of multi-pregnancy are high. Chances of having multiple pregnancy like twins or triplets is definitely higher than a normal conception. And the same reason, chances of having, if you're not placing it properly, If suppose it's not a fresh transfer, not a frozen transfer, the chance of ectopic was slightly higher. So it depends on the, skill of the person also who's doing the embryo transfer. The chance of ectopic, I wouldn't say overall increases, but there can be a risk if you're placing too many embryos, or you're pushing too much more volume, or if you're placing it too close to the tube, ectopic chances are also higher. So those are the things. So ectopic, heterotopic pregnancies, which is also rare, it increases in IVF, that one embryo is in the uterus and the other embryo develops in the tube. So that what happens. Heterotopic pregnancy is common in IVF, multiple pregnancy is common in IVF, and that's the thing.
Yeah, ma'am, a very interesting question from Dr. Ivan has come, and we see in a lot of news reports also, a woman 60 plus conceived, etc., with ART.
Those
So
are
his
the
question is,
person no one publishes in the newspaper because that's very confidential. Somebody who's conceiving after 45, 46 most likely has gone for a donor egg.
okay.
99%.
Yeah, in India
That
also
is,
there is recently like a celebrity singer who died young. His parents, his mother conceived later
came
on.
to,
So what Dr. Ivan is asking is, and can it be used for those ladies IVF who are in menopause but still want to conceive? Like, do they even have egg reserve in menopause, ma'am? Extractable eggs, like you said, it's nearly impossible.
menopause, we can't have egg, egg retrieved from them, but a menopausal lady can conceive using a donor egg. Yes,
Okay, but
that's
other,
very possible. That's very common. We keep on doing even at a young age after menopause. What happens is there is a lack of estrogen. The hormone is not there from the ovary. We give the hormones from outside. We prepare the lining. We use a donor egg, and they get pregnant and they deliver. There's not a problem.
okay. I think, ma'am, we already overshot the masterclass time by around half an hour, and there were many questions. So, if
This
you will,
field is really vast and interesting. If you want in future, maybe we can, we can
we can
focus on
repeat.
small
We
subheadings.
Yeah, we can repeat a masterclass like in another couple of months with the a subheading
With
topic.
subheadings, instead of infertile couple, we focus on male infertility, we full PCOS, or female infertility, we can focus.
Yes, ma'am. I think female fertility, so much coverage. I think male fertility, the often
Yeah,
overlooked.
yeah,
And
definitely. We'll have a talk on male fertility exclusively.
okay, and ma'am, before we conclude, I think you must have answered this question. May have been so many times. People have
Mm.
this belief that natural having child naturally or having a child through ART. Is
Mhm.
there any difference? Is there any risk to the health of the
No.
baby who's gonna?
No, there's no risk as such because there have been many studies. This question has been raised right from the beginning, and it has been, the first IVF baby was born in 1978. So it has been more than 46 years. This question being raised for last 46 years, and we have the proof now. A lot of meta-analysis, the evidence is accumulating every year that no, there is no increased risk of congenital anomalies. I mean, not significant increase in the congenital anomalies in the babies who are born out of ART or IVF.
I think, ma'am, there was a Netflix series also around it, like the struggles around the first time after
See,
so many.
why the anomaly would be higher? Somebody just I told you, it's above 40, she wants to conceive, I mean, not in the PGT. The male partner's age is high. So that is age related and not related to procedure.
Okay, okay.
Right. You have to
But
compare a
now,
couple who's in the same age group conceiving naturally and the same age conceiving through IVF. So there's no increased risk.
ma'am, but compared to that time and now, like you talked about the genetic screening, you talked about even PRP. I think medical science is advancing. Like you talked
Like
about the
anything. Keep
TICSI,
trying to
like
reverse everything what the God has created.
yeah, like if somebody doesn't have the azoospermia, but through you can extract through ICSI, right?
Yeah.
So probably perhaps,
We do the TC, TISA, microscopic TC, we extract the sperms from inside and inject.
yeah, perhaps in future they will discover that, even after
No,
menopause, there
definitely.
is some
We
egg
have
reserve
no
somewhere, and fertile age would be increased for women also. So
artificial sperms and eggs have already been created in the lab from the skins of the persons. Only thing is now we are just doing it in the research setting on the animals, not just used in the human beings because morphological, I mean, normal looking sperm have been created out of the skin cells, but their fertilization, whether they're able to fertilize or not, that is still to be, we are still working on that, the fertilization capacity. So a lot of work is going on. Even the egg has been made out of the stem cells. The egg and sperms are being made, and they have been testing on animals. So in future, maybe we know one wouldn't have to go for donor sperm or something, and we'll be able to produce from own cells.
Okay. No, ma'am, that looks a bright future as medical science advances. If I saw that Netflix document, series, and we realized how difficult it was for doctors, and now when you're discussing these techniques, things have improved so much. So hopefully, next 20, 30 years, I think the
Definitely.
infertility problem would be solved by medical science.
Hopefully.
Awesome. Okay. Thank you, Dr. Soma, for your time, and thank you everyone who joined us today. And thank you, Dr. Soma, for the patience for 1.5 hours. And
Definitely pleasure, my pleasure, and it was really nice. I mean, for you to have me here, and I could join and answer all those queries. It's my pleasure.
and and this is the last masterclass of this calendar year. And now I think everybody would be going in the festive mode, Christmas and New Year season. See you all in the beginning of next year with a different topic. And thank you, Dr. Soma. And if you enjoyed it, please let's have another session with you
Sure,
around a
sure,
different topic sometime next year. Thank you.
sure.
Thank
A
you.
very happy New Year, Christmas greetings, and a very happy New Year to everyone.